whether to go and stent it. I don't know there are any clear indications or true indications. So basically in coarctations in less than 2 years or less than 10 kg is almost always surgery. And balloon dilatations were done previously, but mostly they end up in high rate of waist stenosis, so it's hardly been done. Almost always the surgery gets a good results. These are one of the earlier articles, a decade or more than a decade earlier. But now, as you all know, it's again surgery. So just looking at it, in the last maybe 15, 20 years, we've been practicing 3 or 4 coarc stenting. So it's looking for the indications. Obviously, one is a bridge towards surgery. And rarely a single ventricle palliation, I don't think it should include in this. For the Norwood stage 1 hybrid procedure, you may do a stenting. So technically it comes as stenting in a coarctation in less than 10 kg, but I think it's a different setting altogether. And very rarely a definitive treatment in those slightly older kids, the weight may be lesser, probably can consider putting a stent and then redilate it later. And a few rare situations I was thinking of when I was looking back at my own practice for the last 2 years. So just give you a standard scenario in which a newborn presents with shock. You know, basically they will have renal failure, multi-organ damage. And then most of the time we will be able to stabilize the baby on prostaglandin, inotropic supports, ventilation, usual stuff. And then the surgical team takes over. Very rare scenarios, the patient may not improve, then comes our interventional role once in a while. So there's one example in which we had gone through an axillary artery approach. I think it's almost always easy to have an axillary artery approach because femoral arteries are quite difficult to palpate, especially when you have severe coarctation, patient's shock. So axillary artery is quite more easier than less from muscular damage. We had a good presentation of Hemant on this. And then, you know, a tight coarctation here, we have 4 French sheath, and then almost again, it's all predominantly coronary hardware. You use a coronary stent or a balloon. Here, it's only a balloon, and the final result is fair enough, good, decent flow to the lower limbs. So patient is stabilized, and then probably mostly a month in time, it comes back with the waist stenosis. The case 2, again, is some contribution from PCS side, because I think me and Dr. Shine is around, I don't know, we were a colleague in Amrita when I was working in Amrita. We were like, all the surgeons had left for PCS side, so the patient came in a pretty bad state. So we went ahead, again, dilated it because I thought may not be able to go in the next day or 2. So thought of go and stent it on ventilators, multiple inotropes. So used a coronary stent, I think 3.5, 3 mm, 3 into 12 mm coronary stent, and deployed it. Probably if you're stenting, it tend to use the shortest stent available so that it becomes easier for the surgeon to remove it. They will cut across and remove it usually. So the complete correction was done after 3 months later because stenting it, patient improves, went home, came back with a restenosis a month, 2 months later. So we'll just give you 1 or 2 rare scenarios which came across. It was a 5-month-old baby who came with severe LV dysfunction, moderate to severe. There was a coarctation, mild coarctation, gradients were 20, 25 only. But as you all know, there's a possibility of DCM coexisting with it, or it could be a low gradients caused by the severe LV dysfunction. It was referred first to the surgeon. The surgeon was a bit hesitant to touch it because said, if it is DCM, then I'll be in trouble. I tried to convince him, obviously it was difficult. So then he said, why don't you go and stent it? And then if it LV recovers, I'll go and remove it and repair it later. So maybe it's a borderline indication. I went ahead and because other options do a ballooning. If I don't get a good result that LV doesn't improve, I thought better go ahead and stent it. So I don't have the images here, done almost more than 12 years ago. So that did the coarc stenting, but it didn't improve immediately. So still don't know. Maybe on the first week, usually you find this after you do a stenting or ballooning, the LV improves almost instantaneously within 24 hours or so. But it took almost 2 to 3 weeks, if I remember right. So to improve, and then it remained because I could put a slightly bigger renal stent, 5 mm or something. So almost for 2 to 3 years, it remained a lost follow-up because it was a patient from North India came in South here. Until then, 2 to 3 years, it was going well. There's another, again, a bit rare one. There's a bicuspid wall with a severe aortic stenosis and a coarctation. So anyway, I'm going in for a balloon aortic valvotomy. So it went and ballooned it and then did the angiogram here, which showed a coarctation. The PD was still patent, but the coart segment was quite tight here, not well imaged here because I had a good echocardiogram. So, and then did a ballooning, and then there's a post angiogram. post ballooning, it was flowing reasonably well until there was no restenosis up to 1 year follow-up. And one final slide is a 4-year-old is again the marginal like 10, 12 kg. And then there is a tight coarctation here put in it was the distal arch measured some around 9 millimeter and then put a Andra stent over a 12-3 balloon, 28 stent over a 12-3 balloon. So closer to 10, 12, beyond that, probably you can do a regular stenting like any other coarctation, and then it's a good result here. There's only one few papers I could get those 5 patients stented for babies, preterm babies less than 1.5 kilo, in which I think they used around 3.5, 4, and 5 stents, I think. And then taken by the femoral root. On the follow-up, they said almost all had lost the femoral pulses, and one patient had a aneurysm, which they put in a covered stent. I think two comments I could make on this was like we could have been gone through the axillary route, so the femoral artery loss would have been avoided. And then probably smaller stents should be enough to carry on for 2 or 3 months. They waited for almost 200 days for the complete repair. And then probably, as Masini was talking earlier, it was availability of bioabsorbable stents, but completely changed the picture maybe 5 years, 10 years down the lane. So you can probably take care of almost all the coarctations in the cath lab. So stenting in the less than 10 kg is quite a rare indication, but if indicated, it may be life-saving. Ballooning will suffice in almost all cases, but then few cases you may end up stenting to get abolition of gradients and for the later surgery.